trying to push forward vaccine equity. And we've got an exciting morning lined up for you. So you really are very welcome. It's actually the second event of Ireland's People's Vaccine Alliance in partnership with Doctors for Vaccine Equity, the Irish Global Health Network, and a whole lot of immunologists and scientists around the country. I'm Cliona O'Farrelly, Professor of Comparative Immunology at Trinity, and I'm delighted to welcome such a fantastic lineup of speakers and contributors from here in Ireland and from around the globe to talk about the real problems we have around global vaccine inequity and how to get vaccines and vaccine technologies out across the world. We're encouraging colleagues to show their support by signing the event mission statement, and I ask you all to contribute comments and questions and queries in the chat so that we can come to it at the end. I'll be chairing the event along with my co-chair Christine Kelly, who I'll pass over to you now to give a couple of comments before Jim Clarkin gives us the opening.
Yeah, thank you very much, Cliona, and I'd like to welcome everybody here today as well. I know our time is precious and I really appreciate the support for this really important topic. We're here today to discuss real solutions for vaccine equity. The format will be around about the first hour. We'll hear from our invited speakers from both Ireland and abroad. And then for the second half, we'll take questions and some discussion from our panelist members. And then at the end, we'll wrap up and discuss ways forward, because obviously what we really want is some action to come out of this as well. There will be a live transcript of this on YouTube, and you'll also be able to access it afterwards if you want to distribute it to other people you think will be interested. You can use, as Cliona said, the Q&A feature at the bottom to ask questions, and we'll get to them hopefully at the end of the speakers. So I would like to pass it over to Jim, who is the CEO of Oxfam, and will be opening up with a few comments for us.
Thank you so much, and good morning, everyone. I'm really delighted to share this stage with such distinguished speakers from Ireland and around the world. And it's very energizing to see the level of solidarity that we have across the spectrum for vaccine equity. I mean, we're all aware of how extraordinary the scientific effort was, heavily supported by public funding, I have to say, that brought the vaccines into being in the shortest time in history, and the amazing impact they're having here at home. But we also know that in many parts of the world, it may be years before people are vaccinated. This is a global health inequality that's just simply not acceptable. Pharmaceutical companies are telling us that they are on track to produce a glut of coronavirus vaccines globally by 2022, and this will solve the issue. But this issue isn't just about production, but about fair distribution. Despite the recent increases in production, less than 1% of all manufactured vaccine doses have gone to low-income countries. Oxfam's recent report, A Dose of Reality, revealed that Western pharmaceutical companies have delivered just 12% of the doses they promised to COVAX. So it's obvious to us that we won't donate our way out of this pandemic. It's also obvious that much of the extra vaccines to be produced in the next weeks and months will actually be used in booster campaigns in rich countries. Western countries are once again hoarding vaccines at the expense of poor countries. And you know, the longer this goes on, we may be looking at additional boosters, and this can go on and on. But what we've, based on figures from Airfinity Ireland, we're informed that Ireland has already got 14 million surplus vaccines by the end of 2022, and this is a trend we're seeing across the northern world. So pharmaceutical companies are developing partnership arrangements, but these are just simply not enough to tackle the issue. The problem we have is that these agreements will still leave the control of the vaccine production in the hands of just 3 or 4 companies, and they'll still get to decide production and distribution levels for the entire world. So commercial rather than human rights considerations will continue to inform these decisions as they have to date, and making very little impact on overall vaccine inequity. As Dr. Tedros from the WHO said, he will not stay silent when the companies and countries that control the global supply of vaccines think the world's poor should be satisfied with leftovers. So as Oxfam, we had been working on the HIV/AIDS global health crisis for many, many years. And it was only when generic production of these essential life-saving medicines were allowed that the poorest and those most vulnerable in the world were able to get the treatments they needed. Pharmaceutical companies didn't come through for poor countries during that pandemic either. So we haven't seen evidence that this will change during this pandemic. At the time, people will recall there were dire warnings about the negative impact of generic production on innovation and future medicine production, and that quality issues would be a huge problem. This never came to pass. Ireland's opposition to the TRIPS waiver and its lack of endorsement of the WHO CTAP programme is really damaging Ireland's international reputation as a champion of poor countries and as an advocate for human rights. Last week, Oxfam was among a number of groups that have formally petitioned the UN under the International Convention for the Elimination of All Forms of Racial Discrimination. This petition argues that countries opposing removing intellectual property barriers on all COVID-19 medical technologies through a TRIPS waiver are actually facilitating the inevitable and racially discriminatory rollout of the vaccine and other COVID health care technologies. This is a test case, but Ireland will be impacted by these deliberations, even though it's not specifically mentioned in the petition. We were a founding member of the People's Vaccine globally and here in Ireland. And at its essence, the People's Vaccine campaign is quite simple. We believe that the answer to vaccine inequity in the world is to produce more vaccines, to increase the pie rather than fighting over a share of it. We believe that the fastest, fairest, and most cost-effective way for doing this is to ensure that the technical know-how currently retained by a very small group of global pharma companies is shared free from patents with the many companies across the world who are ready and willing to produce vaccines. And again, I like to remind us that so much of the investment in developing the vaccines that we have today was through public funding. And as a result, this should be a public good. As COVID continues to devastate countries, exacerbating existing inequalities and reversing hard-won progress in fighting poverty, bearing in mind that we had made good progress between 1990 and the time that this started, and we see a huge reversal of this across the global south, we reiterate our request to the Irish government to join the growing number of countries supporting vaccine equity. And we really can't see a good reason why Ireland wouldn't. Ireland must stay on the side of the people, learn from the lessons of the past, and avoid needless loss, suffering, and harm. It's great to see such a broad range of people from the scientific and medical and immunology community here today, adding their voice to this important call. We have said all along that no one is safe until everybody is safe. We know that the answer to ensuring everybody will be safe is to ensure that everybody is vaccinated. As our own President Michael D. Higgins has said, solidarity in an interdependent world must mean standing shoulder to shoulder with those in other countries, especially poor nations with fewer financial resources, so that, for example, vaccines are made available, accessible, and affordable to all. I'd like to just again encourage everybody on this call to join in the campaign. It's really vitally important. It's very accessible, and we see oftentimes when we have these types of campaigns, they can be very convoluted and complex. In this instance, we believe that the solution is quite simple. Ireland needs to support the TRIPS waiver at the WTO. The talks are coming up again in the next few weeks. It's a very important moment, and we would encourage everybody to put as much pressure as they can on Ireland to be part of the solution. Thanks very much.
Thank you so much, Jim, for giving us that really clear kind of vision and mission statement for what we're about. So now we're going to hear from a range of people who can develop the themes that Jim has so eloquently introduced. And I'm delighted to welcome Faith Osier. Most countries in the world, believe it or not, have a Society of Immunology. And we're going to hear later on from the president of the Irish Society of Immunology. But all those societies are gathered together into an international union. And Faith is the president of this International Union of Immunology Societies. And she's in that position because of her world-class performance in immunology. She is an immunologist and a pediatrician and an educator from Kenya. having done fantastic work in malaria immunology and the development of that vaccine. And she's a visiting professor in the Nuffield in Oxford. So I really look forward to hearing your views. Please, Faith.
Thank you very much, Cleona, for that kind introduction. And it's an honor really to be here with this panel today, distinguished panel. Thank you so much for inviting me. And it's such an important topic. I'm really happy to share my insights on the issue of vaccine equity. I work for IAVI, the executive director of the Human Immunology Lab at Imperial College London. And our mission there is really to translate scientific discoveries into accessible global health solutions. So it fits right in with the topic for today, which is vaccine equity. And so just a quick thank you to my funders who pay for my time and acknowledging the support that we get at IAVI. And so the first thing I want to say is that it's already been mentioned, only 15 countries have reached the target. This is the data from end of September, but you can see that out of 54 countries in Africa, the proportion that have reached vaccination targets of 10%. And, one has to reflect even the setting of a target at 10%, whereas countries in the West are vaccinated at 70% and over. We set a low boundary, a low barrier to start with. And even with that low barrier, we're just not getting there. And, you'll all have seen this data. And I think that's really why we're here today. The inequality gap is just too wide. Here, again, you can see the COVID vaccines distribution around the world. It's very clear the dark colors is where we're getting vaccines out. You can see where Africa is at. The disparity is obvious. Here's the COVAX initiative that we just had. And the COVAX scheme was such a good idea. It's a mechanism for countries to donate vaccines. But you can see what's happening, that what's actually delivered, what's on promise, what's announced, and I hope you can just see the light bars, that we've got a lot announced, but actually it's not translating into doses delivered. And that's the gap that we're really talking about. And I just want to point out that it's a complex environment. While our lecture today is focused really on, we've got specific objectives for the Irish government to look at vaccine and technology transfer to Africa. But, the situation in Africa is complex, and I just wanted to highlight some of those challenges so that we can think more broadly. In terms of the capacity for testing, that's a significant problem, that the numbers we report are almost certainly underestimates because we don't have that capacity for the diagnostics. So while we watch the numbers, while we say, oh, the numbers are low in Africa, actually there's a major underreporting problem. And there's now publications coming out showing that the proportion of people who have died, for example, with COVID is much higher than what the estimates are telling us. So we're probably severely underestimating the problem. We've got a high burden of co-infections that are known risk factors for COVID. We've got HIV, we've got malaria, we've got tuberculosis. And so what's happening is a vicious cycle. People who are already having a hard time, it's just getting tougher and tougher. We've got poor healthcare systems. Again, nothing new. We don't have ICU capacity, we don't have ventilation capacity, we don't have oxygen. Again, a situation that's just compounding on an already weak situation. And then now with the pandemic, we've diverted our resources from other diseases. People that were getting supplies for HIV, for malaria prevention, all those things have been interrupted by the pandemic, again, worsening the impact. Today, we're focusing a lot on pharmaceutical manufacturing capacity and this reliance on developed countries. Actually, in addition to campaigning for big pharma to share and tech transfer, we're also campaigning for African countries to stand up and take responsibility. But there's got to be a two-way discussion here. There's got to be input from our side as Africa, but with the support from the Western side. And then, the economic situation, we've observed it in the West. Economies can't be sustained with lockdowns. And so for Africa, it's all these things melting down into a really dire situation. And COVID brings to the fore things that we've known about, we've gotten complacent about. Oh, that's the way Africa is. Oh, yeah, they don't have this, they don't have that. And now COVID has just really brought everything back to the surface. And I think it's a good time to take that momentum and try to bring about long-lasting change. So this was a graph from the same paper I referenced in the previous slide, really highlighting that the co-infections. So as we think about COVID and the impact of not vaccinating people for COVID, we should just reflect also on the fact that this goes beyond COVID. So we see that we've got all these comorbidities that I've mentioned. HIV is high, tuberculosis is high, malaria is high. And so by intervening with COVID, we would have knockdown effects on additional comorbidities that are present in Africa. So I really want to encourage us in this effort that while it's focused on COVID, it's interrelated with a lot of other health challenges in Africa, and having an impact on COVID will extend to these other areas. And so in terms of real solutions for equity, I think we have to think long-term, we have to think medium-term, we have to think short-term. And underpinning all that is strengthening capacity for doing vaccine research and for doing vaccine manufacture in Africa, in low and middle income countries, and really facilitating that exchange. However, it's not that easy because it's a complex environment. In the short term, to me, the priority is saving lives. I'm not usually one that likes to show pictures of children suffering, people dying, etc. We see enough of it on television already. But in looking at numbers, in looking at figures, we get detached from the fact that there are real people in real pain who are, and that's why we're here. And so I put this picture today from a Global Fund report, just to bring it back to us that we're talking about people, we're talking about lives, we're talking about a situation that's already dire, and that we can make a difference through the actions that we take.
Thank you so much.
Sorry, there's just one last slide.
Okay, thanks, Faith.
I'm sorry, I double pressed in my enthusiasm, but just the last slide is just to say, in the medium to long term, I think that there are opportunities that we can leverage the momentum. There's already vaccine production that's happening in different parts of the continent. So we're not starting from zero. And so I think that we need to leverage this momentum and not let the moment go. I think there's innovative partnership models that can be in place, you know, the way that it's worked before with the whole IP situation. We need to work around that and be innovative. We need to strengthen capacity. You see, there's big chunks of Africa where there's absolutely nothing happening. I think there's lots of opportunity there. We have to think about reagents and equipment and the supply and maintenance of those things. We have to leverage the African Union, think about regional vaccine hubs. We've also got to think about the regulatory framework. So to introduce vaccines into a continent, you need that support for clinical trials and the regulatory framework. So I just want us to think about the ecosystem and think broadly. While we've got a focused campaign, which is good, it has to fit into an ecosystem. So thank you very much.
Thank you so much, Faith, and especially for giving us that last slide was so important. It is the beginnings of a roadmap for us. So thank you. I'm very aware of the fact that you've got a pressing engagement, and so you won't be here for the discussion later on. But we'll let you know about the issues that come up. And once again, thank you so much for joining us. So if I can now introduce Achal Prabhala, who's the coordinator of Access IBSA, which is an arrangement for getting vaccine access to India, Brazil, and South Africa. And so Achal has some experience in starting down exactly the roadmap that Faith has laid out for us. Over to you, Achal. Oh, and can I say just before you start, yes, I've given Faith a little bit of leeway. We're hoping to get all the speakers done in an hour. So we've asked for 6 minutes. So Achal, I hope you won't mind if I interrupt you if you go over the 6 minutes. But
you're welcome to.
Thank you. And thank you so much for coming. It's a real pleasure and an honor to have you here.
Thank you. I'm Achal Prabhala. I work in Bangalore in India, and I've worked for about 20 years on access to medicines in primarily India, Brazil, and South Africa. The best way I think I can use the 6 minutes that I have here is to ask a question which some of you might be wondering about. Recently, 2 antiviral pills were discovered to have what their companies describe as very good effects in curbing the effects of COVID. One of those pills is from Merck and the other is from Pfizer. They're both antiviral pills. And they, just today, the second of those companies, Pfizer, announced that it too, like the first Merck, had licensed the production of those antivirals to pretty much any company that wants to make them anywhere in the world, to supply them to about between 95 and 105 countries around the world. What that means is, through a system called the Medicines Patent Pool, which is based in Geneva, Pfizer and Merck are allowing the almost unlimited supply of their antiviral pills for COVID in every single poor country in the world, which are countries usually defined as having a low income or a low middle income, according to World Bank classifications. And the question that many people might have on their minds is that, yes, this isn't a perfect solution. It leaves out a lot of middle income countries who are in between the state of being rich and poor, but it is a pretty good solution. And the question is, why can't Pfizer do that with its vaccine if it's willing to do this with its antiviral pill, which presumably is also going to bring in a lot of money? And what's behind that is a set of things that we need in terms of monopoly barriers to be dismantled for vaccine production that aren't required in as much quantity for the production of what is called a small molecule, an antiviral pill, like Pfizer's product. Vaccines require 3 layers of monopolies to be dismantled. The first is intellectual property, and that is the substance of what South Africa and India are asking for at the World Trade Organization with the TRIPS waiver, along with 100+ developing countries providing support to that request. But the second layer of monopoly protection on vaccines is the know-how, a step-by-step manual for how to produce the vaccine, which in the case of older vaccines is essential to save time, because people around the world, vaccine manufacturers, might know how to work that technology generally. But unless they have the very specific set of instructions that these companies have used to make their vaccines, it's going to take them some time to figure this out by themselves. It's not the easiest thing in the world to do. So having the know-how, literally a manual that provides a detailed description of the quality steps and the process steps that should be taken in order to make the same vaccine is essential. In the case of mRNA vaccines, the messenger RNA vaccines, which are very new, this is absolutely vital because no company in the world has made an mRNA vaccine, and indeed no company had even in the West prior to last year. The third element that is also necessary is a license. So think of this as a formal letter from the vaccine manufacturer saying, I, Pfizer, authorize company X in country Y to make the Pfizer vaccine, in addition to giving them the know-how. Now, the TRIPS waiver proposal that's being discussed at the WTO, which at the moment shows no sign of success, it is highly unlikely that at the end of this month, when the World Trade Organization holds its most important organizational meeting, what's called the Interministerial Conference, where countries get together and figure out where they stand, there is no indication that the TRIPS waiver will be resolved by that time. And that's mainly because of opposition from the European Union, which of course Ireland is a part of. And I do hope that there is a way by which Ireland can use its own will to influence what the European Union decision on this is, as well as influence what neighboring countries such as the United Kingdom, which continue to oppose the TRIPS waiver, will do, both towards the end of this month as well as in the future. But the TRIPS waiver, while people assume that it's primarily about intellectual property, is actually also about the transfer of this know-how. And how does the TRIPS waiver achieve that? Well, so the TRIPS waiver includes a clause that asks or explicitly allows regulators in countries who have received dossiers from vaccine manufacturers, right, which in turn contain the know-how that's required, to be able to share that dossier, which is usually kept confidential, with any manufacturer in the country who wants it. This is an unusual arrangement because the World Trade Organization's rules have never been used to interpret dossier confidentiality against unfair commercial use in this way. But this is a pandemic, and one of the ways in which we can get that manual without the explicit cooperation of a company like Pfizer or Moderna is to allow people that Pfizer and Moderna have shared their vaccine manual with as part of this large dossier containing the safety and efficacy data from various phases of clinical trials, to share that information with manufacturers in the country of that regulator who wish to have it and make the same vaccine. So that still leaves the license part, that last part, unresolved, but it does take care of two very, very important things that we can have in order to make vaccines in greater quantity. And the point of this sort of long lesson is actually to say that it isn't as easy to simply create vaccine production by changes in law. It's not a problem that we can necessarily fix in the law, like we can with pills, like the antiviral pill that Pfizer is making. So aware of that and aware that it's going to be so much easier to create a legal solution to its antiviral pill, Pfizer merely got ahead of that and allowed access to its antiviral pill, knowing that it's much harder to create access to the vaccine know-how as well as a license. Pfizer is not doing that to date. And that's the simple way it is. Now, there is a question of who can make these vaccines. I'm in the middle of an exercise, particularly around mRNA vaccines, to be able to figure out a set of companies around the world, which now number over 100 from Asia to Africa to Latin America, who can produce these vaccines. There are roughly 8 at least within the African continent itself who can produce an mRNA vaccine, because it is a simpler technology that doesn't involve biology. So in fact, the older the vaccine is, the vaccines in India, like the inactivated viral vaccines or adenoviral vector vaccines that we use, they're harder to make. It's only an established vaccine manufacturer who can make them. Whereas mRNA vaccines open up this whole new vista where small molecule pharmaceutical companies with experience in what are called sterile injectables can produce an mRNA vaccine if the monopolies are dismantled. And so there's this enormous capacity of about over 100 companies at the very least, all of whom have exported similar products to the European Union. So they are incredibly qualified to be making an mRNA vaccine, who are not. And the reason they are not is because neither has the WTO, nor have the companies who hold the keys to these monopolies allowed any kind of sharing or access to them. A point that Faith made as a very last point, I want to reiterate, which is that there's a lot of complaining about what Western companies and Western countries are doing to hinder vaccine access in the pandemic. But look, finally, I live in India. We're a poor state, but we're not a poor government. And we are also not an indecisive, helpless government that has no resources at their side. There's a lot more that countries can do to take some of these matters into their own hand instead of just constantly relying on the benevolence and the charity of organizations and countries who have seemed unwilling to provide it so far. So while that might not be that useful to Ireland, a lot of the solutions that are on offer here, if they're not mandated by the TRIPS waiver, if that doesn't come to pass, you can do what Brazil does, is passing its own national version of a TRIPS waiver and trying to create the same set of provisions that allow manufacturers to make something like an mRNA vaccine. I think what's important as a final point is to keep in mind that these technologies were funded in large part by you, and you have the responsibility, therefore, of ownership over them, and that ownership should result in some degree of control over who has access to them. Thanks.
Thank you so much, Akhil. Again, a hugely valuable contribution, and which will stimulate great discussion towards the end. Or in the next half, sorry, not towards the end, the whole second half of this event. Our final international speaker is Professor Tom Maltry, who is a professor of demography and the director of the Centre for Actuarial Research, otherwise known as CARE, at the University of Cape Town in South Africa. He has been deeply involved in trying to address one of the issues that Faith told us about in the development of a system that tracks excess mortality in near real time in South Africa. And it's one of the few such systems in the developing world, and is clearly going to be so important in really addressing this issue. So thank you very much, Tom. Over to you.
Thank you very much, Cleona, and thanks for the invitation to be with you today, and greetings to all of you who are joining us. Faith gave a great overview of the challenges of COVID and vaccines in Africa. And today, really what I want to do is give some additional insight into the burden of COVID drawn from our work in South Africa, and to argue that the COVID toll is most probably grotesquely underestimated in the region, with concomitant implications for vaccine equity in the region. It's tried to say that the COVID pandemic has thrown a stark and brutal light on pre-existing health and social inequalities across the globe. Often forgotten about in this age of aggregated dashboards and instant information is to ask the question, where do these data come from? And do they offer a true account of COVID in the developing world? What do we know about the true mortality due to COVID-19 in developing countries? Usually the answer is surprisingly little or almost nothing. Testing for COVID is wholly inadequate in almost every developing country. This is in part a measure of the functioning of the healthcare system. Does the system have the resources to fund tests, labs to run the tests, collate the data? If you take the countries of continental sub-Saharan Africa as represented on one such dashboard, South Africa has the third highest number of tests per capita in continental Africa. Globally, we rank 123rd. The country in continental Africa with the most tests per capita makes it in at 91st position. Without extensive testing and the appropriate testing protocols, one barely gets off first base. And we see this in the reported number of cases. Botswana has the most reported cases per capita, followed by Namibia and South Africa. Globally, those three countries are ranked 74th, 107th, and 108th, respectively. And yet the reporting of tests and identified cases is, relative to the reporting of deaths, quite good. The infrastructure to report tests and identified cases is relatively unchallenging and undemanding. The identification and recording of COVID deaths requires a highly functional civil registration and vital statistics system, combined with capacity within the health system to identify and report cause of death. Deaths have to be notified timeously and mostly completely. And we know from the UN Stats Division that the quality of civil registration systems in most developing countries is exceedingly poor. According to one of those dashboards, South Africa has the most reported COVID deaths per million in continental sub-Saharan Africa. Globally, we rank 53rd. And yet South Africa is fortunate in having reasonably comprehensive testing and a functioning, almost complete vital registration system combined with a national population register, which we understand well where the holes and deficiencies in those data are. This has allowed us, almost uniquely in the developing world, to track the evolution of excess mortality in near real time. With colleagues at the Medical Research Council, we're able to issue a report every Wednesday evening based on the deaths that occurred in the country through to the previous Saturday night, 4 days earlier. And the story it paints about the impact of COVID in a developing country is exceedingly grim. Since the start of the epidemic, our monitoring system has identified 270,000 natural deaths, in excess of what we would have expected. The number of official reported deaths from COVID is barely 90,000. What we do not know, however, is of this 270,000 excess deaths, the true number of COVID deaths, because while we get notification of deaths timelessly, we do not get information on cause of death in anywhere close to real time. Delays at our National Statistical Agency mean that we will only get the information on cause of death 3 or so years into the future. Not all of the excess deaths, those 270,000, are likely to be COVID. Some will be collateral from the repeated overburdening of our healthcare system. And unlike many other countries in the region, we do have a functioning healthcare system, especially during surges and waves. But we estimate, based on the pattern and timing of those deaths and the results from the testing, that probably 85 to 95% of those excess deaths are attributable to COVID. So that means that actual COVID deaths are being underreported by a factor of 2.5 to 3 times in the most developed country in sub-Saharan Africa. The South African data, supported by small-scale studies in major cities in the region, Lusaka and Nairobi, for example, gives the lie to one of the myths that has circulated perennially based on misinformed interpretation of the data from those aggregators, that somehow Africa is immune to the disease, that it's unaffected. This is simply not true. Yes, the population of Africa is younger, but we have populations with a number of comorbidities, as Faith pointed out: diabetes, hypertension, obesity, and of course, HIV. The net effect is that the real impact of COVID in Africa is likely several times worse than is generally acknowledged. The reason why many think there is no COVID in much of Africa is simply because we do not know where to find the deaths. And this has had further knock-on effects. Perceptions that mortality in Africa is not bad has resulted in diminished vaccine availability and a strong sense that vaccine equity is not important and not an important part of the global COVID story. And while COVID deaths mount in Africa, there's a real possibility of Africa being left behind. South Africa is the most vaccinated country in continental sub-Saharan Africa, and yet even here, not even a quarter of the population has been vaccinated. COVAX has reduced the likely availability of vaccines to the global south by around a quarter this year, all the while wealthy countries continue to both hoard vaccines, more vaccines that can be plausibly used, here's looking at New Canada, or allowing vaccine doses to expire. The fact is that without addressing the problem of COVID in Africa and addressing the questions of vaccine equity, the chance of a global return to any form of normality is going to be highly compromised. Thank you very much.
Thank you so much, Tom. Again, a great call to arms. As usual, we are in these situations, we absolutely need more data and more technologies and better focus of our efforts. Very, very useful. We're now going to hear from Annie Curtis, who's a senior academic in RCSI, as she's here representing all Irish immunologists, as she is president of the Irish Society of Immunology. Many thanks for agreeing to come along, Annie. Over to you.
Thanks very much, Cliona. It's a real pleasure to be here. So just really my job is to represent the Irish Society for Immunology, and we represent over 250 scientists and clinicians working in all areas of immunology in Ireland. So, you know, one of ISI's mission is to make immunology accessible to all. And I think some of our members have become household names due to their science communication. Many of them are on this call, including Kingston, Cliona, and of course, Luke O'Neill. And I think we should remember that that clear, unified message driven by the science has really played a significant part in our country's extraordinarily high uptake of vaccines and buy-in as well to the restrictions and measures which we now continue to be introduced. So immunology research in Ireland is very strong. We continually rank in the top 10 countries in the world, but that, similar to what many of the messages from the previous speakers have said, has been driven by public investment through government agencies like Science Foundation Ireland. As Jim spoke, about public investment that has been made in terms of developing these vaccines since 2020, we also must remember that these vaccines are a product of decades worth of public investment in science. So for medicines, for all medicines, we know that the public pays up to 2/3 of the R&D cost. And, this model of drug development was skewed even before COVID. But with COVID, I think we all realize we have to vaccinate the world probably multiple times over in order to achieve vaccine-induced herd immunity. So really, the model that we have is broken. It has to be changed. And I think if we think about where we would be in Ireland without COVID vaccines, it is difficult to model, but estimates which were given by individuals on this call would suggest that if we didn't have vaccines in Ireland, we would be looking at 10 times more higher deaths in this country. That would be 50,000 deaths and 5 times more hospitalizations. Vaccines have allowed us to keep our schools open and our health service operating to a certain degree. And I often think as well, in a country like Ireland, we can ask individuals to work from home in order to reduce transmission, which has been done just yesterday by the government. And in reality, because of the workforce that we have, that will have a very small effect on our economics. But as Professor Ozier mentioned, you can't do that in countries like Africa. So the final thing I will say is when I think in a very simplistic way about vaccine equity, it sort of reminds me of the housing crisis in Ireland. So I'm a child of the 80s and I have clear memories of listening to people on the Late Late Show speaking about the fact in the 80s, speaking about the fact that they cannot afford a home. My 6 and 8-year-old daughters are now listening to that same conversation on chat shows in Ireland. Housing can only be solved by increasing supply and not leaving it to the private market. And in my mind, the COVID crisis is exactly the same. We have to increase supply and it can't be left to the private market. Thanks.
Many thanks. And again, a great call to arms and a very succinct reminder of what research and science can achieve and how much we need to contribute. So thanks again, how much Ireland can do. So thank you so much. Our next speaker is also a household name in Ireland, Cliona Ní Cheallaigh. She's one of a band of wonderful clinicians in Ireland who've got PhDs in immunology, like Christine Kelly and Niall Conlon on the line. But also Cliona has had a long-standing commitment to equity of healthcare. And she's a consultant in infectious diseases in St. James's Hospital and Professor of Inclusion Health at Trinity College, Dublin. She's extensive clinical and research expertise in immunology, the social determinants of health equity and implementation, and a wonderful voice for equity in Ireland. So Cliona, thank you.
So thanks so much. I was really delighted to be asked to speak at this event. It's something I feel very passionately about, and I see lots of my friends and colleagues here, so that's wonderful. And Christine asked me to highlight the parallels between HIV and COVID and the importance of equity and global access to treatment and prevention. And I think that's such a good parallel to draw, and it was lovely that Jim brought that up already. And I think it's very informative. So Christine and I are both doctors working with people who have HIV. It's such an amazing privilege. It's the medication works amazingly well, and it's so rewarding to be able to go into clinic and know that you can tell your patients they can go back to a normal life expectancy, they can have kids, they can do whatever jobs they want. It's just fabulous. But it wasn't always globally accessible. And if you look back on the evolution of ART, when it came out and was so revolutionary in rich countries like Ireland and the US, it wasn't globally accessible. And it took a huge amount of work to fight the pharma companies who didn't want to release the ability of lower and middle income countries to make generic antiretroviral treatment. And it required a lot of work, partnerships between patients, academics, doctors, global health people. So it's great to see all of those speaking up today. And it also required legal challenges to the pharmaceutical industry on patents. And I think that that's something we need to be conscious of. I noted that the WHO at the time called it a global crime against humanity. And I think that what we're doing now in terms of not enabling everybody who could get access to COVID vaccines to get that is, again, a global crime against humanity. And it is foolish for the same reasons that not giving people access to antiretroviral treatment globally was very foolish at the time. So what you do when you do that is you strip out the healthcare workers and the young people of young working age from the population. And in Africa, for example, there already is a huge scarcity of healthcare workers, and some countries are still suffering the after effects of Ebola. So you're really damaging what's going to happen for years to come. You leave a large viral reservoir. So in HIV, we now know that one of the really important ways to reduce new infections of HIV is to reduce the community viral load. So you can have a conception of whether it's a city or a country or the globe, how many HIV virus copies are out there, and you can do something similar with COVID. And as long as your global levels of virus are high, you're going to get new infections and you're going to get mutations that are going to be resistant to vaccines. So it is a really stupid, in capital letters, STUPID thing to do, not to do everything you can globally to reduce the viral burden. And I think I'm fascinated. So I was just looking up in preparation for this. There was a lovely article, which I can share later, on the benefits to the US of the Pepfar program. And so it obviously had benefits to the people living in Africa, but it had huge benefits to the US. So it reduced imported new infections. It led to improved diplomacy, improved international relations. It led to improved research. It actually improved the antiretroviral market as generics came on. There was increased incentive for drug companies to innovate. And it's actually improved the care of HIV, and it improved research. So there's really meaningful benefits to us in rich countries for sharing the know-how with lower and middle income countries to make vaccines. Why would you not do it? Give me one good reason, apart from protecting stakeholder interests in pharmaceutical companies, that you would not do everything in your power to ensure that as many vaccines are in as many people's arms as possible. And I think as we move into an era of climate change, it's going to be very difficult to ask countries to make sacrifices to protect our climate in rich countries if we haven't shared these. And I think that finally, I've been reflecting on colonialism recently, just out of interest. And obviously in Ireland, we're also a colonizer, but also a colonized country. And I think that we're really reinforcing that we're stripping the resources and the money from poorer countries, and then we are keeping the benefits to ourselves. We're very strongly doing that at the moment with COVID vaccines. And again, I think that will lead to huge political instability and resentment in the future. So it's wrong and it's stupid, and we need to stop doing it.
Many thanks, Ciana, for those inspiring words. Exactly. We have gained so much, it's our turn to, and that's not, shouldn't be just to do with returning, it's to do with just equity.
We don't own it. I mean,
exactly.
They're not ours.
Exactly. Great. Hopefully this is going to stimulate a great discussion. Now we're going to hear from Doug Hamilton. He is with us today in his role as Vice Chair and founding member of the Irish Society of Specialists in Public Health Medicine, something that we were inclined to ignore up to COVID. So his voice has been very important. He is a specialist in public health medicine and a medical officer for health in the Department of Public Health in the Midlands. He's also worked in global health and surgery for 16 years, 11 of which was in sub-Saharan Africa. So really look forward to your words, Doug.
Thank you, Cleona. Okay, good morning all. So I'm here as the Vice Chair of the newly formed Irish Society of Specialists in Public Health Medicine. Now, with all the excellent and clear guidance from previous speakers on what we need to do to achieve global vaccine equity, I thought I might focus on the reasons why we should have vaccine equity in the first place. Like so many others in public health, I had acquired quite a broad experience in health services around the world by the time I settled down to train in public health in Ireland. And one such experience was working for many years in Africa, and some of them for Irish Aid. And so during that time, during public consultations to underpin the budget for the Irish strategy in the late noughties, one of the simplest and most compelling submissions in support of using taxpayers' money for the aid program was simply because it is the right thing to do. This was simple, brilliant. Moral directive is to give to those who have less than us. But of course, we might need to expand more on exactly why ensuring global vaccine equity is the right thing to do. Well, COVID picks out the poorest, the weakest, the most vulnerable. This is because these communities often live in squalor, maybe in tightly packed slums where they cannot socially distance. They often have poor access to hygiene and sanitation, often no clean water to wash their hands. They often have dirty face coverings or no masks. There are often issues with communication, either because they might not understand the official language in the country, or they might simply be illiterate. We've actually seen this. So I'm a specialist in public health, a medical officer of health in Ireland as well. We've seen this in Ireland as well, where vulnerable ethnic minorities are in fact the worst affected, largely for the same social determinants of health, for the reasons of the same social determinants of health. But global vaccine equity is also the right thing to do because already weak health services in poor countries become rapidly overwhelmed and quickly collapse, which means greater morbidity and mortality, not only from COVID, as previous speakers have said, but from other normally very easily preventable or curable diseases and conditions such as malaria, simple diarrhea, or only mildly complicated pregnancy. And I've seen this in relation to HIV and AIDS in Africa when I worked in Uganda and Mozambique. Now pitch that against having access to a safe, highly effective vaccine that crucially works as well there as here. And it does work extremely well here, as we know. It is arguably the only intervention that works as well there as here, which potentially makes it a silver bullet, where very few other public health interventions are realistically achievable. So the net benefit is immensely greater. So success depends on as many as possible getting COVID vaccines in poorer countries. The cynical will say that vaccines will only be wasted in low-income countries. But Gavi, one of the implementing arms of COVAX, and UNICEF have shown that cold chain and effective vaccine or vaccination is feasible in low-income countries, achieving high coverage of basic vaccines in the world's 73 poorest countries. And we've heard of many ways of ensuring that the administration of vaccines is a possibility if we just put our minds to it. But global COVID vaccine equity is also the right thing to do because relative to their budgets, COVID has a much more destructive impact on the economy and development in poorer than wealthy countries because scarce resources are quickly used up, leaving these economies destitute. Recent and important gains in development are therefore quickly wiped out as brittle government systems are paralyzed by disease and death, jeopardize even basic democracy and the rule of law. I've seen this. I worked for 15 years in the middle of the devastating AIDS pandemic in sub-Saharan Africa. But finally, for those without a global conscience or a moral compass, who might feel that suffering on the other side of the world does not concern them, ensuring vaccine equity is still the right thing to do. As it says on WHO COVAX website, with a fast-moving pandemic, no one is safe unless everyone is safe. So we are not safe unless the people in the poorest countries are safe. So why is that? Because COVID outbreaks will continuously erupt in non-immunized populations, like fires that never quite go out, because cinders keep reigniting. And these outbreaks will inevitably continue to spread around the world to Europe and Ireland, seeding new outbreaks here, wave after wave, unnecessarily prolonging the pandemic. And crucially, as it does so, it will continue to mutate, with the risk of weakening immunity affected by the vaccine each time, and again, unnecessarily prolonging the pandemic and our suffering here. So to conclude, I hope those with a global conscience and a functioning moral compass would see this vaccine equity cause as an opportunity to better the world, and that those without will be frightened enough to support it anyway, because it is quite simply the right thing to do. Thank you. And a huge thank you to Doctors for Vaccine Equity for organizing this event and for letting me speak at it and for leading us on this worthy cause. Thank you.
Thank you so much, Doug. More inspirational words and really useful data and facts. And now, after those wonderful presentations, we've heard such a lot. Please do put your comments and thoughts. They're beginning to come in on the chat. Please put them in so that they can guide Christine's discussion with the panelists and with our speakers afterwards. But before we move on to that, Colm O'Gorman, the CEO of Amnesty International, has the really difficult task of bookending this part of the event with Jim Clarkin's opening words. So Colm, please.
Thanks very much, Cliona. And we're just delighted to have so many leaders in the science and medical community join with us. I know so many of you have been really powerful voices over the last 18 months in making these calls in the Irish media and beyond. And we're hugely grateful for your voices and for this opportunity to work with you to identify real solutions to this crisis. We've heard so much today about the compelling case for the ending of this monopoly that's been created on life-saving vaccines that are absolutely critical to ending this pandemic. More than 5 million people have died of COVID-19 to date, and 3.5 million died in the 12 months following South Africa and India first calling for the TRIPS waiver. We need to save lives, and we need to prevent serious illness. And we've heard repeatedly today from health and scientific experts, COVID-19 vaccines are life-saving. They need to be the focus of the global response to COVID-19. I want to be really blunt now, and I can't emphasize this enough. States and pharmaceutical companies are bluntly refusing to do everything possible to stop people dying of COVID-19. It's as simple as that. We're still in the middle of an unprecedented global health and human rights crisis, and it's essential that all countries across the world have access to vaccines as soon as possible. And yet it's very clear that the dominant power in the debate that's happening in the political sphere are the pharma companies, are the companies who have profited hugely from the investment of billions of public funds into the production of these vaccines. And that point has been repeatedly made here today as well. These vaccines are the result of extraordinary scientific endeavor, of investment, yes, indeed, by private companies, but of massive investment of public funds. The defense that's offered, or the rationale that's offered by Big Pharma for blocking the TRIPS waiver of, well, we can't interfere in how the market operates in terms of producing innovative solutions or innovative new treatments like vaccines, for instance, is nonsense. There was an interference in that usual way of working through the sheer scale of the public investment in the production of these vaccines in the first instance. These vaccines were produced through public money. They should be available for public benefit, and that means they need to be available for global public benefit. We know that between 100,000 and 225,000 lives can be saved for every 100 million doses delivered. So as an emergency measure to save lives, surplus vaccines have to be redistributed, but we need longer-term solutions as well. And we've heard about those today. The TRIPS waiver would increase production and access to life-saving medicines. And I was really struck by Akal's comments earlier on, saying that there are over 100 companies who are currently equipped to produce MMR vaccines now, if the IP issue is resolved if we get a TRIPS waiver, if this monopoly on the part of 4 companies or 4 or 5 companies globally is finally ended and these vaccines are made available in the way that they need to be made available, we need at least 11 billion vaccines, and all capacity should be looked into and used to manufacturing those vaccines. We know that there is manufacturing capacity across the world that's not being used. Hundreds of vaccine manufacturers could be drafted in to make more vaccines. And we know we're going to need more vaccines. This commitment that now, the companies, big pharma companies are now ramping up production at sufficient scale to be able to produce sufficient vaccines in 2021 and beyond. We know that's not credible. We know already that boosters are going to be necessary. We know there are huge issues around supply in the longer term, and we simply can't depend upon these so-called reassuring comments around supply now from pharma companies. And then finally, one of the points that I'd like to make in closing these comments, Ireland's human rights obligations here are clear. All states are obliged to ensure access to a full range of diagnostics, medications, vaccines, therapeutics, and other relevant health products to contain, prevent, and mitigate COVID-19, all states. And that's not just within the boundaries of their own state, that's a global obligation that states have. At the very, very least, states have an obligation to not obstruct the TRIPS waiver negotiations. And right now, we know that the EU and other wealthy states, including Ireland, are indeed obstructing TRIPS waiver negotiations. They are blocking the introduction of a TRIPS waiver. That's disgraceful. It is a huge moral failure. It is completely indefensible, and it must end. So as the negotiations continue, and we're near a conclusion in early December, we urgently need EU countries, including Ireland, to support the TRIPS waiver. And it's time for Ireland to be vocal and clear in that commitment. Ireland needs to step up and needs to clearly commit to supporting the TRIPS waiver on a public level. So I know we've very little time for me to be making these final comments, and I'm rushing through them a little bit, but we've had such fantastic inputs from all of our speakers so far, and I'm really looking forward to the discussion that's going to happen shortly. I want to thank everyone for taking their time away from their busy schedules to discuss this, and we hope you'll continue to work alongside us, and we certainly want to work alongside you to support vaccine equity. And then finally, I just want to express gratitude to Doctors for Vaccine Equity, to the Global Health Network, to Oxfam Ireland, our partners in this work, to Dr. Kieran Harkin, to Dr. Christine Kelly, to Dr. Ciara Conlon, and of course, to Professor Cliona O'Farrelly for organising the seminar at such an important time to ensure global access to COVID-19 vaccines. We throw around sentences like moral catastrophe, perhaps at times too easily. They get used a little bit too often. But this is a massive moral catastrophe that we're facing into. This is a human rights and public health catastrophe that is entirely unavoidable, and that's rolling out because of the inaction of states and because of the intransigence of big pharma, who are putting profits ahead of the lives, the human rights and the health of millions upon millions of people across the world. We must call it out. If we fail here, we are party to that moral catastrophe. So please join the campaign. Please get involved. Please raise your voice. Please insist that Ireland and other states finally end their blockage of a TRIPS waiver and ensure global access to vaccines for everybody everywhere. None of us are safe unless all of us are safe. Thank you.
Thank you very much, Colin. And thank you to all of the speakers and everybody who's come along to participate today. I have to say, it's a little bit overwhelming and incredibly fantastic to hear from everybody. Anybody who knows me will know I was very motivated about this topic before, but I'm even more so now if that was possible. I actually just want to start by giving a bit of context to all of this and just bringing us back to kind of March 2020, because I think it's really important to remember when Ireland was in the situation when we didn't have vaccines. And something that Professor Ozier said really struck me as an infectious diseases clinician and somebody who was very much on the front line with these patients at the start. She said, in looking at the numbers, we get detached from real people in real pain. And I think that's the key thing that we have to remember here, is that when you have somebody come into you with COVID-19, this is a terrible disease. It's horrific to watch as a clinician. And a lot of us would have given our right arms to have had something to prevent that for people at that time. And we now do. We have a vaccine that works and is effective. But yet we know that our colleagues in a lot of other countries are going out to work every single day caring for patients with COVID-19 in the knowledge that they can't access a vaccine that could have prevented that situation. So I think it's key that we just kind of start this discussion remembering that the reasons that vaccines are there are to prevent severe disease and death, and that's the primary aim of what we're doing here. So I guess just on that, I might start bringing in some of the panelists, and I know we have kind of a lot of mix of people, but I might be a little bit biased and start with Professor Sam McConkie if he's on the line, and just maybe ask to give an overview, Sam, of what you think the impact of COVID-19 vaccination has been in Ireland, you know, and really from your point of view, how have we benefited from that first course of vaccine?
Yeah, thanks, Christine, and thanks for the invitation to be here. What's really striking now in the last 6 weeks, with very high numbers of people with COVID, is that the rate of hospitalization, according to HPC, is about 1%. Back in the previous waves, it was 4 to 10%. And the rate of going to ICU is 0.07%. So that's much less than it was before. And that's largely because of the success of the vaccination program. So while we're seeing a lot of cases and, you know, we're busy in hospital, a large extent of what we've been doing in the last 6 weeks has been an epidemic of the unvaccinated, sadly. And the vaccinated have to a very large extent been protected, at least from severe disease and death. Unfortunately, people are still getting COVID who've been vaccinated, and the protection from infection is less than the protection from death. But it's quite a different experience now, being a sort of hospital clinician looking after loads of people with COVID in ICU and in the wards this time than it was back in January, and certainly back in March, April, because people are less sick. The COVID has changed. Back before, it was type 1 respiratory failure. People couldn't get enough oxygen into their lungs and were just giving massive amount of oxygen. Now it's often very frail elderly folk who are very thin and often brain dysfunction, who become more delirious, stop eating, stop drinking, and sort of shrivel away. And it's very hard to treat that, and very hard to fix that. So COVID is also, the presentation is different now. So I strongly support not just on Douglas Hamilton's arguments from morality, that will work for some people, but I actually think there's a really strong self-interest argument that for COVID to be dealt with in Ireland or in the EU or America or wherever, it's absolutely essential that it's dealt with in other countries in the world. Otherwise, we'll have what people might call the epsilon variant, but I don't know, we could call the omega variant. It just will continue to evolve into new variants that will potentially spread in vaccinated populations. So as I really like Cléanna Kelly's talk about HIV community viral load, there's this idea of the coronavirus burden of the world, and the lower it is, the less chance of new variants and less evolution happening. We're very much aware of that in Ireland. We've been very successful at controlling individuals who've HIV and communities with HIV in the last number of years in Ireland, and I would like to see that we do the same with coronavirus. So thank you, Cléanna, for that very useful model and metaphor that certainly is one that I've been thinking a lot about. I hope that those who are not sort of active clinicians and treating people with HIV also can sort of understand that, but just the less you have, the better. So I think the vaccine has been transformative here and could be around the world as well.
Thank you very much, Sam, and I agree. I think part of what spurs a lot of us on is the realization that what we did wrong at the start of the HIV epidemic, we're still dealing with now, right? So that kind of delay impacts for decades. So it's really important that we try and get this right now. The next thing, if I can just bring in Professor Kingston Mills on this one. I think it's really important that we kind of address the elephant in the room a bit here, which is the fact that, you know, case numbers in Ireland are increasing. We've recently seen kind of new restrictions being brought in. And a lot of people will say, well, listen, we need to get this right in our own backyards first. I mean, what is your kind of understanding of what Ireland can do to support vaccine equity when it's also in the middle of trying to get cases under control itself?
I think it's very clear that the vaccines, even the mRNA vaccines, which I'm a great proponent of, don't prevent transmission of this virus in most people. So vaccinated people can still transmit, and that's the big issue. That's why we're having so many breakthrough infections in vaccinated individuals. And it's also clear from the data coming out of Israel and the US that a third immunization really does enhance the ability of the vaccine to prevent not just disease, but also infection, at least in the short term. So there's an absolutely very, very strong case for boosting everybody, every adult in the country. So that's the Irish situation. On the other side of the coin, I read a great article in the RTE website recently, which showed that Pfizer, BioNTech, and Moderna made 34 billion, or expect to make $34 billion profit this year on the back of their vaccine. That's $1,000 a second. And clearly they're in the business of making money. But I do want to bring a sort of a note of reality check to those that think it's just a matter of giving a trip waiver and saying, get on and make a vaccine in any country you want to. I thought that Akel's presentation was fantastic. I have to say, I didn't know there were so many countries that could, or companies that could make mRNA vaccines. And that's very, very encouraging to hear that. But this is the way forward. It's not Ireland giving 500,000 doses to a single African country. There's a 5 billion population we have to vaccinate. So it's about enabling countries like the African countries and also India. India have 2 biotech companies can easily make 1 billion doses of vaccine a year, Bharat Biotech and Serum Institute of India. And there, as Akel said, there are African countries can do so well. So to me, it's about enabling those countries to make the vaccines for themselves and for the rest of the world, and not simply about a small country like Ireland giving away 500,000 doses, which will have a very little impact. And it actually might, take away from our ability to boost our population with a 3rd dose. In effect, you've wasted the first 2 doses if you don't complete the exercise. Most vaccines is important, and Sam will know this. That most of our vaccines to children are given in 3-dose schedules, 2, 4, and 6 months. There's nothing dramatic about giving a 3rd dose of a vaccine to get optimum immunity. It's well known you need more than 2 doses when it's not a replicating vaccine. So there's nothing surprising about this, and I think we just have to do it. Thank you.
Thank you very much for that. There's a few good points there, and I think it's important for us to discuss the issue around boosters because it's a tricky one. And I know a lot of kind of especially young healthcare workers have been in touch with me recently saying that they feel very guilty about getting a booster because they're so aware of the number of people who haven't had a first course. And then that's a new kind of difficult decision that people are trying to make. But I think what Professor Mills is saying is correct in that, the data is coming out now for the benefit of boosters and those who have had the first course. But I think it's really important to remember that the single most effective intervention we have for COVID-19, still based on the data, is the first course of vaccine. And that's what we need to get to people. And just to kind of clear up this issue around the boosters, I want to kind of just quote from the WHO interim statement on boosters, because I think it kind of summarizes things quite nicely. And it says that the decisions around boosters are complex, but they emphasize that the importance of prioritization of globally limited vaccine supply is that it's prioritization of prevention of severe disease. And I think that that's one of the things that we have to think about when we're thinking about boosters is how do we prevent severe disease, not just in Irish people, but in people around the globe. And those are things that have to be weighed up, the risk-benefit decisions. And I think we'll come on to it in a bit, but the part about the actual number of deaths within places like sub-Saharan Africa is really important to come into factoring in those decisions. So all of these pieces kind of fit together quite nicely. So next, I'd just kind of like to come on to one of the points that Dr. Annie Curtis made. And I thought it was a very interesting point actually around the extraordinarily high uptake of vaccine in Ireland. And I know I'm kind of on a fellowship at UKHSA at the minute, and I know there's a little bit of jealousy around just how high the uptake has been in Ireland. And I think that she's right in terms of the public buy-in. And I might just come to Dr. Niall Conlon, if he's still in the call, and just ask, in terms of what we've been able to do with vaccines in Ireland, how do you see Ireland's role in supporting vaccine equity around the world? Like where do you see us in terms of our place in pushing for that?
Well, look, I mean, what a great set of speakers. I mean, so inspirational. I sort of see myself, so I'm a clinical immunologist. I'm a little bit of an outsider when it comes to COVID and vaccines. I suppose the reason I'm on this call is because one of the scientists in our diagnostic immunology laboratory, whenever we were getting our first COVID vaccine, said we should really be, as a country, donating one vaccine to other parts of the world where they're not as fortunate as we are. And I thought that was very interesting. That's kind of something I've dwelt on a while, and I tend to listen to this scientist because she's actually my wife as well. There's no doubt that doctors and scientists and nurses and other healthcare professionals in Ireland, many of whom come from other parts of the world, are keenly aware of the need for a global response to this virus. And I think one of the things that I've learned on the call today, or one of the quotes that will stay with me, is we cannot donate our way out of this crisis. So to generate this global vaccine response, it's not a matter of us versus them, or a vaccine in my arm means, a vaccine in my arm is better than a vaccine elsewhere in the world, or worse than a vaccine elsewhere in the world. It's about generating this political pressure to change the approach to vaccine production globally. And I think one of the things that I hope will come out of this is that doctors, nurses, healthcare professionals will put their weight behind putting pressure on our political leaders at governmental and at European level to try and pull this into action, because we're not going to get out of this as a country of our own, irrespective of our own high vaccination rates. We need to try and turn this into a global initiative.
That's great. Thank you very much. So next I will hear from Professor Chris Fitzpatrick, if he's on the line, because I want to touch a little bit on the subject around vaccine hoarding, wastage, how to make more out of what we've got, because we've heard already there's two issues here, which is essentially production and fair distribution. And I think we need both of those things, right, to solve this problem. We're still looking at having to vaccinate billions of people around the world. This isn't kind of over. So I know Professor Fitzpatrick is working very hard there. We can see him literally joining us from the front line. And I'm just wondering if you could comment a little bit on the operations side of things and how many vaccines Ireland are buying and what's happening with them.
It's interesting you asked me that question, because Kieran emailed me last night and asked me for the situation in relation to I suppose, the amount of vaccine that we have and the amounts of vaccine that we have, I suppose, committed to purchase. And although I am a clinical lead for vaccination in the Dublin Midlands Hospital Group, I could not answer that question. So, and I suppose it emphasises, I suppose, the need for transparency in relation to, I don't know what the national commitment to vaccine procurement is at the present time. So, and I think for those of us on the ground, and unlike, I suppose, many of the speakers, it's been a fantastic webinar. Like, I am not a specialist in terms of immunology or public health or epidemiology. So I'm a convert to the vaccination program because I was swept along by, I suppose, the morality of this national effort. So I'm kind of an obstetrician who, in the latter part of his career, converted to being a vaccinator. And like, there's huge support in the vaccination program for global equity. And I think the last speaker made the point that many of our vaccinators actually come from countries where there's actually kind of low vaccine rates. So they're acutely aware of the fact that many of their family members and friends haven't had access to what we're giving. And every day we see the benefit of what we're actually giving in our vaccination centres. So I suppose to me, first of all, I don't know the answer to your question, which I think actually speaks volumes, because that isn't part of the discussion. We know that we've donated some vaccine, and that's the only figure I ever saw in terms of what we actually donated to another country. And in terms of vaccine wastage, like we have meticulous in terms of basically the day-to-day operation of vaccination centres. But the bigger picture, I certainly can't answer the question in relation to that. I think that for me, this is a question of moral political leadership. And if you ask me what this country should do, and I think like hiding behind the EU response is not good enough. Like, the EU has a kind of a checkered history in relation to human rights and standing up for poor and impoverished, disenfranchised. So I think this is a question that we need to ask to Micheál Martin and Leo Varadkar. And I think they need to actually stand up for global equity. They need to push this agenda at a European level and on a global level. And like there was an opportunity recently when the Taoiseach addressed the UN General Assembly. And I think that was an opportunity that was lost in terms of what we could do. I also think it's a question of medical ethics. And like the last speaker, like I'm rolling out the booster campaign and I'm fully compliant with the recommendations of NIAC and the NIO. But I've moral qualms in relation to what we're doing on a day-by-day basis, though I certainly kind of believe that we need to boost the population. But I'm very conscious of the fact that we're giving what others can't get. And we support UNICEF in our vaccination centres and put up their posters, etc. But it's a bigger issue than that. And what disappoints me is that some of our professional bodies that were central to the fight against COVID, such as say the RCPI and the ICGP, and that's just on the medical side, have not really stood up and unambiguously said that they would support a TRIPS waiver, which to me seems to be basically the key to answering kind of this problem. And you know, we had a recent kind of webinar in the RCPI, which kind of supported, I suppose, the principles of global equity. But what I really think we need is actions. And somebody said they were a child of the 70s? I'm a child of the 60s. Okay, so, and I think there perhaps is an opportunity for us to launch a political protest in relation to this, and also to lobby our professional bodies to actually take on board, I suppose, the principles, or to plagiarize the principles of Doctors for Vaccine Equity in relation to what they have advocated for.
Thank you very much, Professor Fitzpatrick, and some very important points in there. I think that brings us on quite nicely to one of the questions that we've received in from Donald Gorman, and I'm just going to read this question out for you all. Ireland apparently spoke against the TRIPS waiver at the EU Council last week. In the run-up to MC12, when European states are defining their positions on TRIPS at World Trade Organization, how can we put pressure on the Irish government to support COVID vaccine equity? They are defending Big Pharma's profits at the cost of lives. So I guess maybe Colin might be able to answer that for us. 'Cause I imagine, Colin, you've got your finger on the pulse with that one. If you're maybe on mute. Yeah, there we go.
The 20, you're on mute, surely has to make its way into the Cambridge Dictionary at some point. Yeah. It has to be the Fins of the Year. Thank you. No, I mean, I absolutely agree. And I mean, I think everybody on this call is pretty much at one on this one. I mean, Ireland needs to step up and needs to do more. I very much agree with Chris Fitzpatrick's comments just now. It's frankly, at this point, not good enough for Ireland to continue to stand behind or to be rather muted in its responses, you know, while it awaits the outcome of EU decisions. I mean, yes, the EU will make a decision on this, but I think I would like to see Ireland being much clearer and much more vocal on the issue. And obviously, I'd very much like to see them voice their support for the TRIPS waiver. It did appear at one point like that might happen after incoming President Biden made his comments on TRIPS, but that's all fallen a little bit away now. It's untenable, in my view, for our political leaders to continue to support these efforts, which serve only the interests of Big Pharma, to block the TRIPS waiver. It's absolutely unconscionable. I think what everybody can do on this is sign up to the campaign. There are links now in the chat. Please sign up to the campaign. Please get vocal. If you're minded to do so, please write to Micheál Martin, to Stephen Donnelly, and to Leo Varadkar, insisting that it's time that Ireland expresses public support for the TRIPS waiver and pushes the EU to stop blocking this life-saving initiative.
Thank you, Colin. And I see Luke has his hand up, so I might just bring Luke in here as well to add to that answer.
Thanks a lot. So I just wanted to add something on the law here, because I'm an intellectual property lawyer. I'm not a health professional, but I'm incredibly impressed by everything everybody has said. And, you know, Colm has been battling some of the representatives of the pharma industry here. And I want to add a perspective from intellectual property law, because it's important to understand what the effect of the TRIPS waiver would be, because this is often exaggerated by the representatives of large pharmaceutical companies like Pfizer. The effect of a TRIPS waiver would be a waiver of international obligations under the WTO system, which would facilitate would essentially remove barriers to allow production worldwide and also trade between countries in the global south. Right now, under the WTO system, and it has happened in the past, that generic medicines have been impounded or confiscated as they've been traded at, let's say, European ports on their way to somewhere in Africa from India, let's say. So, there are problems in the international trade system that a TRIPS waiver would help to solve. The other aspect is that it would, as Achal said, allow national governments to, if they wish, change their own laws to better facilitate that production. And so, the US and some, the UK, other rich country governments could change their own national laws to allow, let's say, data sharing from the FDA, from the UK Medicines Regulator, from the EMA, that would enable some of the transfer of the know-how, because that's often codified in these submissions. But what it would not do, and I think it's important not to take the kind of the pharma exaggeration here, it would not detonate immediately all of the IP that is held over these vaccines. It's quite likely that a lot of the countries in the West and in the rich world would not change their national laws that much. They wouldn't need to, because we already have access to the vaccines. The TRIPS waiver effect is not for us, it is to allow the global south to produce for itself. And as was said earlier on, that is actually how we got out of the HIV epidemic, how we brought that under control. It wasn't through donations. Production in the global south is what did it, because it's only through doing that that you have predictability and security of supply. At the moment, countries in Africa and other parts of the world are relying on donations that are coming in month to month. Some of them are so close to expiry they can't prepare. There's a whole load of problems related to the nature of the donation system. It just doesn't work that efficiently. And there is also, it must be said, a perverse incentive on the part of big pharmaceutical companies like Pfizer and Moderna to keep selling to rich countries rather than selling to poor countries, because they get a higher price for doing that. And so what we're talking about here is not interfering that much in the market for vaccines in high-income countries. It's quite likely that a lot of the profitability will remain in the same way that it has for HIV/AIDS. We still have expensive innovation in HIV/AIDS. We still have new drugs coming online, even though we've had 20 years of generic production. So it's better to think of these as almost like two separate markets, one for high-income countries and one for low-income countries. And what we're talking about here with the TRIPS waiver is not annihilating the high-income market, which is working reasonably well, with a lot of state funding, it must be said, and that's already been said, so I'm not going to repeat that. What we need to do is enable the low-cost market in the global south to take care of itself. And we know from HIV/AIDS that that is not going to interfere that much with the incentives for follow-on innovation in rich countries. And it's unlikely that, if Pfizer is going to make 36 billion this year from selling the vaccine, Moderna is going to make about 18 billion, the sums that they're making are from selling to the rich countries. They've hardly sold at all to the lower income countries. They'll probably still be able to make similar sums from continuing to sell to rich countries, but the mRNA vaccines, not only are they the most effective, they're also the easiest to scale up, as Achal said. So, the TRIPS waiver is not the kind of extreme measure that the pharmaceutical industry is trying to paint it as. It's a very moderate measure. Nobel Prize winning economists like Joseph Stiglitz support it. These are not anti-capitalist extremists, but they're people who understand that this is actually an important way of tackling the problem that has been caused by the private market's lack of incentives to take care of the poor. So that's really all I wanted to add because everyone on this panel has done such a great job of dealing with the kind of immunological issues. I just wanted to add something about what the likely effect would be in law from this measure should it pass.
Yeah, that's fantastic, Luke, and thank you very much. I may well come back to you a bit later for some other non-medical points. But I would want to come to Achal next, just to kind of round up on this discussion about TRIPS, because I think one of the things that is really important for us is to get points of view of people from outside of the sphere of Ireland, which can be a little sphere sometimes. Achal, I would be really grateful if you could comment from your point of view through all of the advocacy that you're doing. What would it mean to other countries for Ireland to support the TRIPS waiver, to stand up within the EU and kind of put their hand up and say, yes, we're one of the countries that's going to support this?
It would mean a lot, but let me just say, it would also mean a lot to do it publicly in some kind of official way, regardless of what the EU position is. Yes. So obviously there are negotiations underway. And if I may offer, I think, a contradictory assessment of where those negotiations are at. The United States has made nice public gestures towards support of a TRIPS waiver, but hasn't really followed that up with any private negotiations or bilateral talks to advance the text of a TRIPS waiver, right? The European Union is doing exactly the opposite, and it's so perverse. I think this is not particularly clear on the outside. The European Union has made horrible signals on the TRIPS waiver in terms of its non-support for it, but weirdly, behind the scenes, is engaged in talks in some fashion to try to advance a textual agreement on something that can constitute something that is useful for the WTO to do in the pandemic, right? So it's not like there are good actors and are bad actors, or that the EU is, pure evil. I think that there are people within the EU Secretariat who are trying to see what kind of agreement they can reach, right? None of this is public, however. So firstly, I think it's really important for Ireland to support the TRIPS waiver, but to also do so publicly, loudly, and now, right? Regardless of what the EU position is, to the extent I think it's possible as a sovereign right for Ireland to do so, right? Should its government or its, a large group of people within the country wish to do so. It is, I think, however, really important to understand why we're doing so as well. And I want to follow on from what Luke just talked about, which is that the primary argument against doing so, which is sort of like a wink, wink, nod, nod argument, is, look, we're willing to take some of these actions, but in fact, intellectual property is the lifeblood of the innovation industry, especially for pharmaceuticals. So firstly, it's the Chicken Little argument, which is, let's do this now and the sky is going to fall on our heads, right? And this has been said a lot of times, and the sky's never fallen on our heads. So it's an extremely resilient sky. Like that's, I think, the lesson we can learn from the last 20 years of access to medicines work is that the sky is staying in place, right? Well, I mean, as long as, global warming doesn't undo it. But the fact is that when it comes to arguments that have more currency with the public, let's say in Ireland, right? When you speak to people who are even kind of on our side of saying, yes, we need to vaccinate the world, Ireland has a role to play in it, the European Union has a role to play, you will find, like I did over the last year, that many people believe truly, that especially mRNA vaccines cannot be manufactured anywhere. And this is really absurd because, in fact, it's the inactivated virus vaccines from China and India that have been used in the billions that can be manufactured by the fewest people. Like if you were talking about those vaccines, I'd say yes. Gosh, I mean, those vaccines, they have such high standards of safety and specifications, very few companies can make them. But when it comes to mRNA vaccines, practically anyone who's in the pharmaceutical industry can possibly make them. The list that I'm working on, which will be released later this month and at the beginning of next year, is a list of literally over 100 companies across Asia, Latin America, and Africa who all have this capacity. They have the investments required to put it in. They literally need the keys to get into the same safe deposit box, right? I mean, the gates just need to be unlocked and this can happen. So it's, I think, very important to think of that as an argument as to why the TRIPS waiver is being advanced, right? Which are what the practical effects of it are, rather than a sort of abstract ideological struggle, you know, against either capitalism or multilateralism or the, you know, World Trade Order or whatever it is.
Thank you very much, Achal, for that. I think it's kind of so important to put all of those points, and we've had questions as well. I think people are a little surprised to hear that, you know, there's so much capacity for production out there that's not being used. And I think that that's another big point, you know, and I think often, you know, I hear representatives from pharma saying, well, it would take a long time and, you know, you'd have to get the resources. But I think a lot of that's already there, and we're not fully utilizing the capacity that we have as a globe to be able to produce vaccines.
Not at all. May I just interrupt you for 1 second to make a point which illustrates this really well? If you look at, so Pfizer and Moderna are under immense pressure to increase the volume of output of vaccines they can produce, right, themselves. And that's an option. If they can magically create 10 billion vaccines a month, then, you know, people won't put this much pressure on them to license other companies to do so, right? So what they're doing is, and what they've been doing right from the start, by the way, is going to companies with no experience in anything. Pfizer's newest licensee is a manufacturer of scientific equipment that used to make their refrigerators. I'm just saying, they have a full manufacturing license now and are going to be producing hundreds of millions of mRNA vaccines. Their expertise is refrigeration, right? So there's absolutely, you know, when you look at the companies that they themselves have gone to scale up their vaccine production, it is extremely clear that this is the easiest technology to reproduce if you allow somebody else to do so.
Yeah, thank you very much, Achal. I really appreciate you coming on and talking to us. And we've got a couple of hands up, so I'm going to go to them and just kind of wind up this topic. But I think it's really important. One of the things that kind of really hit me when I was researching about TRIPS waiver is that patents don't belong in a global health crisis, right? So, you know, patents don't belong in a pandemic. It's not the time to be making money. And I think really we need to try to move away from this model towards a model which is based on public-private partnerships, because that's where the innovation comes from. And I think that's really what we need to be underlining. So I'm just going to go to Doug and then Professor Maltry for some comments, and I'm trying to bring in some other points as well after that.
Thanks, Christine. And thanks, Achal. That's really interesting that there isn't really anything that the big pharma would lose by a waiver on TRIPS, insofar as they're selling to the north mainly anyway, and the loss in terms of monetary loss would be low. I was working in NIH when we were pushing hard for Ireland to get the last seat in the UN Security Council. Global security is closely linked to global health. And any instability in health, whether it be at national level, international level, leads to either homeland insecurity and potentially instability in terms of international peace. And the US has recognized this, that health security is closely linked to global security. And I'm just wondering, like, if we want Ireland now to use their seat properly after we won that seat, and actually be useful at that seat, why not put this as an agenda point, the TRIPS waiver, in order to improve global health security and overall global security? I don't know whether that's been considered, but I think that politicians could be pushed in that direction.
It's a very important point, and I think it's something that we'll touch on in a little bit, just for that bigger context, Doug, as well. And then Professor Maltry as well was coming in on that.
Yeah, thank you. I just want to strongly agree with what Achal said, and certainly in the context of South Africa and the deal with Pfizer. The deal which has so far been struck with South Africa with Pfizer is a fill and finish arrangement rather than a full technology transfer. And I think one also needs to look beyond the current COVID crisis. One of the astonishing things about the mRNA vaccines is how they've opened up doors to solving a number of public health crises particularly in sub-Saharan Africa. I think of recent innovations relating to malaria, to HIV. And so creating the capacity to actually transfer that technology to the countries that are most affected, and using the COVID pandemic to actually capacitate countries to be able to respond into the future as these vaccines develop, I think is a further reason for pushing this really hard. Thanks.
Thank you very much indeed. It's really useful to get those outside experiences. So I'm going to move on in a little minute from kind of this general discussion, but one of the things that I just wanted to touch on, and it was raised earlier, is about Ireland's contribution to donations and COVAX. And I think it's important just to get these figures right. So it was quoted that Ireland have donated vaccines through COVAX to Uganda. That was 355,000 vaccines. There's 1 million more pledged, but we haven't seen any kind of update following that pledge on actual kind of timescales for delivery. And there's also been €7 million donated as well at the start. So I think that's where we're up to. I think we can do a lot more in terms of contributing to COVAX as well, as can all countries. Only 14% of pledges that have been made have actually been delivered. So I think one of the take-home messages for me from all of this is that these kind of initiatives where we're looking at centrally distributing vaccines, these are short-term solutions, yes, not long-term, but we really need to get fully behind them and really need to support WHO and other partners with those kinds of initiatives as a country, I think.
Mute.
Sorry, accidental mute. Yeah, I was just going to say I'd like to move on because I know that our virologists and epidemiologists have been patiently waiting for their turn to speak as well. And so the next thing I really just want to come to is, as an infectious diseases physician, I always like to look at infections kind of from a global point of view. And one of the things that worries me is this discussion around the global viral load, right? Because we know that that is a thing that we worry about, is the amount of virus that's out there, because we're so physically and socially interconnected as a planet that whatever happens in sub-Saharan Africa in terms of virus will quickly affect us in Ireland as well. So I wonder if Jonathan Dean is still here. He's maybe had to... Jonathan's there, yeah. So Jonathan, I know you've been doing absolutely stellar work for the country, so thank you very much. In terms of the genomic epidemiology, I wonder if you could chat to us a little bit about variants, where they come from, you know, how quickly they get from one country to another, that general kind of overview of how interconnected we are in terms of the virus itself.
Sure, and thanks, Christine, for, well, I say thanks, it depends how the rest of the discussion goes from this point onwards, but I do appreciate the opportunity to take part in quite an esteemed panel of contributors. How the virus itself terrifies me, quite frankly, is the fact that it is, or it's proven to be very, very capable of changes that have an immediate and rapid knock-on effect on its transmissibility. Fortunately, generally speaking, that hasn't necessarily translated into the pathogenicity, but certainly as far as how the ongoing evolution of the virus into its newfound human host, it's certainly kind of already shown, if you like, through the alpha wave and now the delta wave, that some relatively insignificant genetic changes can have a very severe impact on how well the virus is capable of spreading through the population. And the fact that you're looking at Delta in a background of at least partially vaccinated population in the Western countries, certainly, it's something to be quite concerned about going forward. And I suppose really the reason that I say it concerns me or terrifies me is maybe a little bit too strong, but in the context of that global virome, indeed, so that the variability within the virus itself across a global population is that you have that complete absence of any information on the circulating variants in those countries that have little or no detection in the first place. You can't identify samples to subsequently sequence and then put that into the global perspective if you can't identify the cases in the first instance. So everything that we see, obviously we have a lot of information. I've said it before in other fora, but it's like an unprecedented global effort to sequence this virus. It's the most sequenced virus, it's certainly in history, and even locally, as you say. And I don't want to take any credit for this. I'm involved, obviously, through the process, but have had very little actual hands-on in the generating of those sequence data. But we've moved from a situation where by the end, well, between the first case being identified here at the end of February last year through to the end of December last year, we had just shy of 1,100 sequences generated for all of those cases, all those individuals. Whereas now we're looking at a situation where we have capacity for 1,500 or more cases being sequenced per week. And unfortunately, we're in a situation where we can meet those levels and more with the number of cases that we have available to us. So that's just choosing Ireland, who haven't necessarily put that much by the way of an investment into that side of things, to the certainly obviously like the diagnostics, the tracking and tracing, and a lot of effort has gone into that at the national level and continues to be. One thing I will say is that to have the diagnostic, and indeed with Cleona on the call, can't not acknowledge the research history as well, but the sharing of the information, the sharing of data has been absolutely critical to the success of what we do see from a diagnostic point of view as regards to SARS-CoV-2, because were it not for the sharing of the whole genome sequence back at the end of January last year, if it weren't for the WHO releasing their primer and probe sets for the real-time PCR detection assays, if it weren't for the likes of the guys over in Nottingham releasing the whole genome sequencing protocol in February, you would have had any number of disparate methodologies, attempts to try and reinvent the wheel and reinvent the wheel. So again, it's I suppose a lesson learned from maybe the Ebola pandemic epidemic, back at the early 2010s, where you had a lot of accusations for the various different bodies who were sitting on their data, that you had national and international efforts to go in and tackle that particular challenge, but people were more concerned with, I don't want to say look concerned with their own CV, but there was rather than everything being devoted to the greater good and the public health efforts, it was more concerned with the generation of data for the internal gain, essentially, and that we certainly. There are commercial companies making money off the back of testing and tracing. That's absolutely true. But at the same time, there is no commercial test if there hasn't been research and development in the first instance. So very happy to say from that point of view, there has been, I suppose, a precedent set in terms of how we could approach the therapeutic side of things, if not necessarily the diagnostic.
That's great, Jonathan. Thank you so much. Really, really important points there about sharing. I want to just call on Professor Gerald Barry next, because I think Jonathan's kind of alluded to this, which is the importance of strengthening our global health systems. So from the point of view, from a virologist point of view, how important to you is it that, these health systems are in place globally, rather than looking at them from a nationalistic point of view?
Yeah, hi folks. Thanks a million for the invitation to come along today. It's a real privilege to listen to everyone speaking on such an important topic. It strikes me actually that it's kind of crazy that we're having to have this discussion in a way, that this is actually an issue in the world during what is a ridiculously important topic, obviously. But regarding the virus, I think if we look at this from the virus's point of view for a second, I think we have to realize that we aren't just dealing with one single entity here. What we're dealing with is a cloud effectively coating the world. And that cloud consists of many, many, many different versions of what we call the COVID-19 virus. And that virus is effectively carrying out an experiment on humans at the moment. And what it's doing is it's sampling and testing the human immune system and seeing how good it is. And figuring out ways to overcome that immune response. Because ultimately what a virus wants to do is it wants to move from person to person to person, or from animal to animal to animal, or whatever entity it infects. And it wants to be able to do that in as efficient way as possible. And it is learning all the time about how to deal with our immune response, whether that's in vaccinated people or unvaccinated people, in order to allow it to replicate as quickly as possible and then get from person to person. And because this is a new virus in the human population, it is naive to our immune system. And so that is driving change within the virus across the planet. And in effect, what we're doing by having this inequity of vaccine is we're encouraging infections in the world. We're driving up the burden across the world in terms of illness, obviously, but we're also encouraging the virus to continue at a very rapid rate to learn how to overcome our immune response. And that is going to drive change in the virus. And it's, in effect, if you were to design an experiment that would lead to new variants, we are doing the perfect experiment at the moment. We're creating populations that have low levels of vaccination, and we are allowing that virus to run amok among the population in certain countries in a completely uncontrolled manner. And that is the perfect environment to create new variants. And I look at what's happening here in Ireland, and without doubt, there is a massive short-term approach to dealing with this pandemic. At a national level, government and NEFID, to be honest, do not look past the short term. There is no long-term planning. And in fact, if you look at, and not to get too central on Ireland, but if you look at the current or the newly published HSE winter plan, within that they talk about testing and tracing. And they're already talking about how they're going to wind down testing and tracing in 2022. So already they're planning for this thing to go away on a national scale, rather than actually planning to deal with this on a longer term basis, because this virus is not going anywhere. This is a longer term issue. And so that's on a national scale. And I think, unfortunately, every country is doing the same thing. They are worried about what's coming tomorrow and the problem they're dealing with today, rather than looking on this on a much broader scale and thinking about, okay, we need to deal with today, but we also need to deal with 6 months or 12 months down the line, because in the environment we're living in at the moment, we are not looking at the long term. And, you know, I wonder about the advice that's being given to government on these kind of things. And I really do question the kind of scientific advice that's been given to them if they don't appreciate, the potential for these kind of things. And that's not to say that a new variant is going to come along tomorrow. It may not. These are kind of random processes. But I think we kind of need to plan for those eventualities. And one of the main ways to avoid that is to vaccinate people. It's very simple. And to get that out to as many people as quickly as possible to drive down that virus burden across the globe. Because it's no good if you protect Ireland when the virus is raging elsewhere, because it will come back to bite us continuously until we sort it out across the world.
That's great. Thank you very much. Again, just such an important perspective for us to hear. I'm going to bring Professor Cahill Walsham next. I'm delighted that he's here to join us, because I think it's really important to kind of get that context from a modelling point of view as well. One of the things that's striking me listening to all of this is, the risk that inequity throughout the world poses to us as a nation, but also, to the world in general. And I think, there was a comment earlier about kind of people looking at it from a selfish point of view or not. But I think even if you are looking at it from a selfish point of view, when it comes to healthcare, when it comes to infection, the only way to deal with it is from that global perspective, and everybody essentially will benefit from that. So maybe Professor Walsh, if you're able to kind of bring in your expertise there as well.
Yeah, I think you're right. And I think we've heard from a number of commentators already. And I mean, the last set of comments there, I think what Jared mentioned, that this is a new pathogen. And so, in the initial phases, what we saw was this acute response to the pathogen. That's why people were getting very sick and very ill. And with the protection of vaccination, the body becomes used to seeing the pathogen at the very least. and this element of direct protection. So the fact that people don't have a severe response, and so the level of severe disease and hospitalizations and CCU utilization has gone down. It means that we're able to deal with the virus. However, I think the challenge has been, of course, that we've seen increased circulation and increased intensity of circulation of disease. And then it seems that it makes sense for us to look at perhaps boosters to provide the additional protection. And I think Kingston's very right that they are available to us and they will provide additional protection. And people shouldn't feel bad about that because we have high levels of circulation of disease in the community. The people, of course, who don't get the direct protection of vaccination are people whose immune systems perhaps don't respond in the same way to vaccination. That might be the older people, and it may be people who just, for one reason or another, their immune response isn't as strong as others. And they're the people who are most vulnerable in our own society at present. And even with a booster vaccination, that's not going to solve the problem. And we know from the cases in critical care and that among the vaccinated, that this is the key challenge that we're facing here. So having the vaccines used, I mean, I think sensibly to slow down transmission of disease makes sense. But we also have to do other things at present. We know mathematically that we aren't going to get to a position of herd immunity, certainly not without vaccinating children. And so we can't just simply rely on that at present to reduce down the burden of disease in the community. And in the meantime, of course, we've plenty of other diseases that we're concerned about. We're concerned about RSV and we're concerned about flu. And that's a burden on our healthcare system as well. The benefit globally is that we will give direct protection to people if we have access to vaccination for those communities. And we also do something to reduce the circulation of the pathogen globally, which will indirectly benefit us. And so it seems selfless to say, oh, we should we should provide vaccines to the rest of the world, but actually it's going to benefit us in the medium to long term as well. So this is something definitively that we have to do, and we simply can't rely on vaccines have brought us a long way here, but they're not the solution, the only solution that we have, and we need to do more here to reduce the intensity, if you like, of the circulation of the virus, and can't rely just on innovation after innovation. It makes sense that primary protection is provided to this novel pathogen elsewhere as well.
That's fantastic. Thank you so much. I think we've covered a lot there. I'm sure there's lots more that we didn't fit in, but I guess this is just the start of a conversation. Hey, so I think in terms of actions going forward, there are plans to obviously petition government, because really that's where the action needs to happen on this. There's three main things that we're asking them to do, which is rational use of vaccines in Ireland, play their part in distribution through COVAX and other means, and then play their part in supporting trips and increasing production of vaccine. So what we'd like people to do, if possible, is to sign their support either through our, there's links in the chat that you can sign the mission statements, and there'll also be a letter to the Taoiseach requesting a meeting to discuss these points. So if you can sign those things, that would be great. And also if you can all use your own individual platforms, because I think the louder the unified voice we speak with as a community, the more impact this has. And I think, we've seen that as a community, we really do have significant power, and I think it's our responsibility to use that. There will be a recording of this on YouTube if anybody wants to go and watch it afterwards, or send that link around as well. And I'd also like to take a minute just to thank everybody who has contributed today. I'd also especially really like to thank Oxfam, Amnesty, and the Irish Global Health Network, who have been incredibly supportive of us. So, I really can't speak highly enough of them as well. And it just goes to show how important these relationships are as doctors and scientists and who like to advocate for their patients. I might just actually hand over, Dr. Kieran Harkin's here with us, and I know I've been very privileged to work with him in Doctors for Vaccine Equity, and I might just hand over to him for a few final words before we hit the 12 o'clock mark. You're on mute, Kieran.
Thanks very much, Christina. So I'm just overawed by everybody's contribution, and I'd just like to say on behalf of the People's Vaccine Alliance and the Global Health Network and ourselves, we're really so grateful for the time you've taken out of your busy schedules to come and make such meaningful contributions. It's really been very heartening, and I think this is a beginning rather than an end of our step, and we certainly look forward to seeing how we can harness all the energy and intellect really that's come in. And I think on the one hand, you've got government, and on the one hand, you've got 3 or 4 pharmaceutical companies saying, leave it to us, just trust us, and we'll make everything will be fine, while they're making, I think it was the figure, $2,000 a second at the moment for their vaccines. On the other hand, you've got a group of scientists who don't really have got any particular interest other than doing the right thing, who are saying, listen, you actually must ensure vaccine equity, and it really should be a no-brainer. And I think people don't. I think it's our responsibility now to get this message out to the general public, because ultimately that's what the politicians will do and respond. And again, thanks so much, and particularly Christine, you've done an amazing job in tying everything together, and I'd like to say thank you very much as well. Thank you.
It's a great team. Thank you, guys. And I guess watch the Twitter page and the Irish Global Health Network website and our website, and there'll be